Okay, can you all see this? Are we good? We're all good. Great. Okay, fine. All right. Well, good evening, everybody. This is the second of the clinical discussions or lectures or webinars um, based on topics that really have been of concern to a lot of people, really. Um, and so I'm going to tonight talk about IPR. Now, interestingly, when I thought about this, I didn't think there'd be that much to talk about, but actually, as you'll see, there are a lot of slides and a lot to talk about. So let's start working through this. So those that don't know me, I'm James Taylor. I'm a general dental practitioner in the north of England. I do implants, orthodontics, restorative dentistry, cosmetic dentistry, and I've been doing SureSmile for about 3 years now, since probably since 2020, early 2020, and I'm now their UK clinical expert. And really, what's allowed me to really hone in with SureSmile, and particularly the type of treatments I do, is that my background isn't just orthodontics, but it's restorative dentistry as well. And so I'm able to bring all those different aspects to play and build uh, a method of treating patients that really doesn't just rely on moving teeth, but looks at all aspects of cosmetic dentistry and aesthetics, which is really key when you're actually planning a treatment. It's not just about orthodontics and straightening. And I think that's where a lot of people fall down. They're looking at specific orthodontic regimes and not really considering what we were trained to do. We were trained to create smiles and fix teeth. And we're all used to picking up a drill and drilling a hole in the tooth, but yet the delicacy and the intricacies of a bit of IPR cause a lot of stress and trouble for a lot of dentists. And so what I'm going to do hopefully is break this down and then build it back up again and show you how we use IPR to really improve the orthodontic alignment, but also the other benefits as well that IPR gives us as part of your treatment planning and regime. I'm a key opinion leader for SureSmile. I do a lot of CAD CAM as well. And my practice in, let's say, in Leeds, it's a pretty new practice. Um, and we're just all private. So anyway, interproximal reduction, IPR. Again, as I said, we're all used to cutting big holes in teeth. We pick up a drill, we'll cut a class 4 or class 2 or whatever cavity, or do a crown prep, and not think twice about adjusting teeth as needed. But a lot of the one-to-ones I've done, and also the CISs, Natasha and Christian, have really noticed that there's been a lot of angst and fear about how much IPR people do, when and how, and should they do it, should they do it? And actually, people aren't doing enough in many cases, and it's actually causing more problems. And so I'm going to break this all down tonight and show you how we can actually take this topic of IPR and this asset we have that we can use to really help our treatment planning and our treatments moving forwards. Um, so IPR is essentially the reduction of interproximal tooth enamel to assist orthodontic tooth movement. We're creating space to move the teeth. We can improve the aesthetics of the teeth by recontouring the teeth as part of the IPR. Part of that involves actually helping to remove black triangles. When we're rotating teeth and the papilla's not fully developed, it creates big triangles and is a real aesthetic issue and concern that we have as cosmetic dentists, which essentially, if you're straightening teeth and creating a smile, you're a cosmetic dentist, whether you see that or not. You're generating a smile, you're changing how someone looks. So all these aspects, not only improving the alignment, but how that alignment affects the shape of the lips, the shape of the smile, are all really, really important. And we also use IPR to camouflage class 2 and 3 malocclusions. If someone's got a class 2 div 1, or where the front teeth are a long way forward with a large overjet, using some IPR can give you that space to pull those teeth back or retrocline things. And same with a class 3, you can use that on the lower arch to tip those lower teeth back. So we can camouflage a lot of skeletal problems, a lot of dental incisor misalignments by using IPR rather than taking teeth out. And I'll show you some cases where it really it's like, oh my gosh, well, I'm not going to tell you, you'll see shortly anyway. By assisting tooth alignment, by creating space, we can remove the need for tooth extraction. Okay, if you've got, you need to create space and you need 4 millimeters, let's say, you could take a tooth out, you could close space a bit, or you can use some IPR, generally around the mouth, and create that 4 millimeters that way. Tooth high width discrepancies. There's lots of teeth which sometimes are too big or the wrong shape. They're fan shaped or big triangles. and we need to just correct the shape, and IPR will help us do that, narrowing the width and therefore giving a better proportion. And we also use IPR asymmetrically when we're correcting center lines, um, which again, I'll be able to show examples of all these later on as we develop this whole discussion on how we use IPR. So like I said, it can remove the need for tooth extraction. I put on there 5 millimeters of space. You can do 0.5 millimeters in multiple contact points rather than moving a lower in size. So there's lots of ways IPR really help our planning, but not only helping it in terms of creating the space, but I'd much rather aesthetically, mechanically adjust a tooth by 0.5 millimeters, or actually the interproximal space by 0.5, so that's 0.25 at each contact point, than take a whole tooth out and try and then close the space, and actually deal with the fallout of what's left, which is normally an undeveloped papilla, loss of soft tissue height, and all that other stuff that comes with taking a tooth out. As far as the dental aesthetics, we're removing black triangles, improving the shape of triangular teeth with narrow gingival, immersion from the actual gingival margin. So very narrow teeth with wide incisal edges. We want to kind of, if we can remove some of the edges where they touch, we can get those teeth close together and remove black triangles. We can also develop the papilla that way as well. So as an example, you've got teeth here which are pretty triangular shaped. Black triangles will develop. We can do the IPR, and this is me and my iPad, but it was a very nice way of just demonstrating that, and actually create space and bring those teeth together will help eliminate the black triangles, improve the tooth width proportions. So many reasons why you would use IPR in many cases, not just to create space. So the next question really, and some of the discussions I've had with clinicians is really, how much is safe? How much IPR should I be doing? The question is to think about it in a smart way. Okay, so use IPR in a way that's going to actually help you and assist you. Sometimes do it in different places than where it's obvious as well. And there's a case that one of your colleagues has let me show where on a one-to-one we discussed this, but actually there was a much nicer way of treating the patient, which actually helped aesthetically with the IPR, but also helped solve a problem further in the mouth. And again, it's about thinking smart and trying to use IPR in the best way, but also in the safest way as well. So it's case specific. Okay, what, when, and how. Every case is different. Every case has a reason why you would or wouldn't, and every tooth should be really considered individually as to why you would or wouldn't use IPR. So it's your own clinical judgment. We're all trained as clinicians. We all have our own hat on as far as decision making. It's hard to rely on someone else to do that for you. You'll have a vision as to what you want to see. You dig a hole in a tooth and you're going to put a white filling in it. Well, you have a vision of how that should look. And if it's done wrong and you don't do right, the wrong color, that's not quite as it should be. So you have a vision of what you should be achieving. And when you're seeing a patient to align the teeth, you will have a vision of what you want to achieve and how you want to achieve it. This will be also key to the discussion we have at the next webinar, where it's actually prescribing your treatment plan to the actual laboratory. It can't be up to the lab to determine how you treat this patient. It's got to be your plan, your vision, your way of treating, getting that patient from A to B. And the judgment on how you do that is very much your decision. As far as whether you take a tooth out, whether you use IPR, the patient has to be involved in that as well. Some patients are really worried about having their enamel adjusted. When you explain that it's glass, essentially, there's no live tissue in there, they kind of then relax a bit. And it's all about understanding your patient's requirements and expectations as well. So that all falls into this clinical judgment decision. There's no pre-prescribed method for all cases. During the one-to-ones, I've heard people saying that 0.2 millimeters is the maximum IPR you can do. And that's very far from the truth. And we'll come through that in this discussion later on. So really, tonight's discussion is about opening your eyes to how I treat patients, showing you what I do and how I've used IPR maybe a bit more than other people will do, and take it to a different level sometimes in how I treat patients pre-actual scanning and how we actually move forwards. And then actually, there's do you do IPR at the beginning or during this treatment? Do you stage it? The one thing we need to, and again, at the lab chat, we'll discuss it, but one thing is you cannot specify with SureSmile when the IPR takes place, apart from stage 1 or before stage 1. They will either stage it as the algorithm lets you or allows you to, or it will all be at the beginning. You can't say please IPR at stage 10 because the software won't allow that. Some other systems will, but SureSmile doesn't. I believe they're working on a way of doing that, but at the moment you can't do that. So anyone that sends a plan saying please do IPR at stage 10, you might not get that back conforming to what you've requested. Just so you're all aware of that. But we'll discuss that with the laboratory chat next time. So there's plenty of data and research, and this paper by Crane and Sheridan showed that IPR does not increase susceptibility to caries and periodontal disease. So you can do stripping of enamel; it doesn't cause any problems. It doesn't make it any more vulnerable to decay or gum disease. So that's the first thing to get out of the way. IPR is safe as far as the decay history of the tooth is concerned, and also as far as periodontal disease is concerned. This was also shown by another trial, showing that even if you use topical fluoride, it doesn't help. The IPR itself is okay on its own. You don't have to use topical fluoride or other adjuncts to help protect the enamel. It will remineralize, or the surface you'll get the pedicle reforming. We all know how that works with the saliva. So essentially, IPR is straightforward. It's easy, it's straightforward, and you don't really have to worry about it after you've done it. The next question is, how much should we be doing? How much IPR should we be doing? And this study recently, it's a systematic review, so it looks at lots of different papers, and this actually talks to us about actually looking at the quantity of enamel interproximally on each tooth. So this gives an indication of really what we're dealing with. How much enamel are we actually dealing with on each tooth? It also showed a few other things, that actually the enamel is thicker on the distal aspect of the tooth. And there's no difference between genders, but there's been ethnicities. And so you'll see in a minute that actually it is very safe to do IPR, and basically what they say as part of this study is that, you can comfortably remove up to 50% of the enamel, okay? Now, I'm not suggesting you do that, but when you look at the numbers that people are removing, 0.1, 0.2 millimeters, that's way away from the 50% maximum that you should be removing. And anything less than that is essentially safe to remove, okay? So you don't have to be too worried about the enamel or how much you're removing. And if it's hard to see this, but if you look closely, you'll see that on an upper central, for example, you've got around 1 millimeter of enamel on the mesial aspect between the dentine and the actual mesial edge. So it means that you could theoretically take approximately 0.4, 0.5 millimeters of the mesial aspect of an upper central. Now, you're not going to do that. The maximum I do in most cases is 0.5 millimeters of the contact point, which essentially is 0.25 each side. You'll see a bit later on, I can occasionally ask for more, but 0.5 millimeters as a general maximum for any of the contact points, giving you 4 millimeters for 8 contact points or 5 for 10 is safe. And it's backed up by research to show that as well. So they're saying less than 50% is fine. And they're also saying that the numbers on here give an average of really between 0.7 millimeters and I think 1.1 for an upper incisor. So 0.25 millimeters movement reduction would be safe. So 0.5 any contact point, I feel, and it's my judgment based on the research, will be absolutely fine to remove of the contact point, and that would involve 0.25 of either side of that contact point, whether it's between a 2 and a 1, or a 1 and a 1, or a 2 and a 3, or whatever it is. As you go further back in the mouth, actually, there's actually you can actually do more IPR on an upper 6 and a 5. There's actually more enamel. You could theoretically do more than that if you wished. So how do we do IPR? Well, normally there's lots of different ways of doing it. Dentsply have SpaceFile, and that can be used either manually, either in your hands or with a holder or on a handpiece. But we'd like to use a strip for about 0.2 millimeters or less. So a diamond strip, either a serrated one or a full diamond one. You start with the thinnest to work your way up, whether it's 0.1, 0.2, 0.3, wherever you're going. And like I said, Dentsply SpaceFile, I use that, but I'll use other techniques as well. I'll use the straight strip, and just you'll work out what works best for you. 0.2 to 0.4 millimeters you can use a handpiece, you can use space files still. There's oscillating handpieces you can use. There's no correct way of doing this. It's what is comfortable with you. You're removing an animal. You're all dentists. We are all dentists. We use a drill daily. We can cut. We can do fine adjustments. And so, actually, removing a bit of enamel using a strip is straightforward. So don't worry too much. You can also buy, I'm sure many of you have seen them, the space, I don't have a picture, but the space which specifies exactly how big the gap is, 0.1 to 0.5 millimeters, they're available. You can buy those quite easily. And you can just check really how much IPR you've completed. But a lot of the actual files themselves or the strips will tell you what their thickness is. So once you've got it through, you're at that space anyway. So I go back up to 0.5 millimeters of a fine diamond. And I use a fine diamond a lot more than I use anything else. So when I do my IPR, I'm actually using a fine diamond to actually reshape the tooth rather than just do a flat contact point. Sometimes I'll use a wedge to push open that contact point to free it open, and then I've got a much easier access to that. And that's when the teeth are kind of abutting together. And I'll talk to you about how to do it another way in a minute. But I'll use a fine diamond burr majority of the time when I'm doing anything over 0.3 millimeters. We're polishing composite fillings all the time. You all do bonding. We're pretty nifty with these little machines. And so imagine the tooth that you're doing IPR on is just a composite filling, and finish it as you would a composite. Give it the shape back. Much nice result. Don't just strip it and leave it, keeping it flat. So again, back to what we were saying, we'll use all this for discrepancies of tooth height and width, centerline correction, asymmetric IPR, and I've got cases which I'll show you a bit later on. So some of the traditional no's, something people, again in the one-to-ones I keep hearing, is that you should only complete IPR when the contact points are parallel and touching. Well, that's very nice, and I'd love that to be the case, but that isn't how patients come to us. They don't come to us with teeth that are all aligned, that are just touching from IPR, from edge to edge, where you can do IPR on. It's not so straightforward. So we need to really think outside the box, okay? And so what I do, and I've kind of looked at how I work, and I've changed how I work based on what I feel gives me my best outcome for the patient and for the treatment to progress, and also in the healthiest way as well. So using minimal IPR of 0.2 millimeters only is a no. As far as I'm concerned, you're going to get nowhere with that. If you're limiting yourself to 0.2 millimeters, you're on a hiding to nothing, because you're not going to be able to deliver the cases you want to deliver. Aligners use IPR quite heavily. I do a lot of expansion of arches, but if you're not used to expanding an arch and you've not done fixed orthodontics before, then it can be a bit scary. And especially if you're not using low dose 3D to help your planning, just expanding arches is difficult. And again, I'll show you a case later where that's kind of happened, and it can get a bit scary, and increasing the IPR would definitely help that situation. As you said previously, the research shows you can remove up to 50% of the interproximal enamel safely. The average upper enamel thickness of enamel is 0.8 millimeters, so on the mesial aspect. So you could theoretically do 0.4 millimeters of IPR on each surface. That would be 0.8. I'm not advocating that. I'm saying that wouldn't be unsafe, if that's a way of saying it. I don't know how many of you know what round tripping is. If you're going from A to B, you want to travel in a straight line. If there's a big diversion, you're going to go around the houses, use a lot more petrol, and you're going to, go up the hills around the backs. Round tripping is where you can't move a tooth from A to B directly, and you need to make adjustments to the tooth and move a tooth out of the way to get another tooth back where it needs to be. A bit tricky to kind of get your head around, but essentially, looking at this diagram here, if these teeth were as they are now, round tripping would be where I haven't numbered them, but a couple of the teeth would have to move forwards, to move one backwards, then to twist one back. It's a kind of juggling teeth to get them in the right position. What you really want to do is just get them in the position immediately, rather than pushing one forwards, one back. That's going to increase your risk of possible gum recession, of resorption, all sorts of issues, increased treatment length times, etc. And if you're going to use IPR in a case like this, you don't want to be using a disc. But what I do, I would reshape the teeth. So I would get a fine diamond, and I would modify the shape of these teeth and do my IPR at this stage. So round tripping, which is moving the teeth in ways which you don't want to move them to get to a point. Remember, it's like the tile game when you move a tile from A to B and then move another tile, and you got to move everything around to move another one around. IPR early on in the treatment will eliminate the need for that, and that's why when you're told or people advocate only doing IPR when the teeth are contacting, it's something that which you need to avoid, because that's something that we just wouldn't do. Sorry, that's my bell ringing. But ignore that. So IPR is done in a way. I'm sorry, I do apologize. IPR is done like this, using fine diamonds to reshape the teeth in a way to avoid round tripping. That's something that we should all be avoiding. And so only doing IPR when the teeth are contacting, I'm advocating that you avoid that. And actually, because we're dentist clinicians, because we know how to shape teeth, there's no reason why a dentist, anybody doing aligners and actually planning this, can modify the shape of teeth with a fine diamond, do the IPR at this stage, and then move the teeth. Because you know how much the IPR is. If you've planned for 0.4 millimeters or 0.3 millimeters, you know you're only taking 0.15 or 0.2 off each edge of the tooth. And you can absolutely do that quite easily by just reshaping the teeth. So I'm very much an advocate of actually doing IPR early on in the treatment, before you make the movement, to reduce the amount of round tripping, and it also allows you to carve those teeth and shape them as you would want them to be when they were finished. So essentially, it's pre-treatment IPR or very early treatment IPR. Now, on the SureSmile website, on the SureSmile portal, there's also a help section. And if you go on there, it will explain to you how the IPR works. And it's very important that if you've not been on this, so you understand what you're looking at and how it works before you start actually treating patients and doing IPR. And it talks about the different colors, whether it's a gold or a black. Gold is where it's scheduled. White, where it's planned for future aligner. Gold's this aligner. It's important that you actually go through this and understand it, because when you get your plans back, you need to understand exactly what you're getting from the laboratory and how to do the treatment. So just kind of pushing, go on the SureSmile help section on the portal and put in IPR, and it will give you the information you need. And that's what I did in here to show. It talks about different aspects. You can track your IPR by saying what you've done at each stage. It just will really help you move through the process of treating the patient in a more controlled way, give you more confidence that you're actually doing what you need to do when you need to do it. One thing that's interesting moving forwards is that we can now do sequential distalization using IPR. I don't know if many of you know what that is, but if you do, it's where you're actually slowly moving teeth back in stages to then create space in the front using IPR in a sequential way. And they'll stage that for you now. So again, this is on the portal. If you didn't know about it, you can now do sequential distalization and request that. So look, back to the out of the box thinking and treating with IPR. But like I said, what I try and do now is I'm trying to do pre-treatment IPR and the laminoplasty and bonding. I'm trying to make my life easier using IPR to actually get me through the treatment in a more controlled way, in a way in which I'm going to get a better result for the patient. So, for example, let's look at this guy. He was a class 2 Div 2, really deep overbite. He said, I want my teeth straightening. And it's like, he's got no, I mean, where do you even start? And for a start, it's going to be a compromise. I know for a fact, I'm not going to be able to give him a class 1 occlusion. He doesn't want gums, he doesn't want surgery. He's a totally deep overbite. I mean, it's a really difficult case. But what I did notice, when you look at his teeth, he's got chips, he's got bits broken. That I knew that the lateral incisor on the right was quite narrow compared to one on the left. And then also the centrals are quite wide. So got this tooth height width misalignment and disproportionate sizes. And also with respect to the lateral and the lateral and the central, things just needed a bit of tidying up. And so again, we'll go through, class 2 Div 2, I fracture chips and incisors, tooth height width discrepancies. And look at the lower incisors as well. You can see how they're totally worn. So just as an aside, I mean, I don't know. There's no way you're going to move those lower centrals with aligners. I mean, there's just, even if you put attachments on, there's nothing to grab onto. So cases like this, absolutely, I'll do pre-treatment enameloplasty, pre-treatment bonding, and pre-treatment IPR to help me get through the treatment. And this is what we did for him. We actually did some modification to the centrals, made them the right size, added to the lateral on the right, modified, did some IPR distally on the left too, built up the layer incisors as well. At least then I knew that I could actually grab those teeth. I could move them properly. I knew I'd need IPR. So I actually did the IPR before I even scanned him for the aligners. So this is pre-treatment IPR and pre-treatment nanoplasty and bonding because we're restorative dentists, a lot of us, and you do this on a daily basis. There's no reason why, once the patient understands what you're doing, they will buy into this. They will understand that actually, for a better result, let's do this. And it also means your plan back from SureSmile will be a much more comprehensive plan because you'll see the actual final results. You're not just going to see a result with teeth that are a bit uneven that you then need to bond at the end. Very hard to visualize that. This way, at least then you can get your gingival zenith correct. You know if your incisal edges are going to be correct. You can really plan properly. So pre-treatment is by far, for me, in many cases like that, which are compromises anyway, really going to help you move forwards. And again, I mean, the IPR I've done there on the centrals, I don't know, what's that, 0.8 millimeters, maybe 0.6, but I've done it for a reason as part of a restorative aesthetic improvement to his teeth to aid with the final outcome. This is another case which I'll be treating shortly. And again, you can see the layer incisors are heavily worn. And again, there's no way we can treat this without actually building up those layer incisors because there's just nowhere to go. The aligners aren't going to be able to grab those teeth. And so we need to do some IPR. We need to do some bonding. You can see a bit close up here. And so what I would intend to do here is I'll do some IPR, I'll do some bonding and build those teeth, and then at least I can see how I'm going to be moving those teeth. So when I show this patient the plan moving forwards, he'll see that actually he can see the final result in a way that's more controlled, and I'll be able to get the gingival margins correct. A lot of the work, a lot of the hard work in terms of IPR, it's already done, and then we'll be there. So I can't advocate this enough. If you feel competent doing bonding and with a fine diamond, then absolutely. If you're going to be treating the patient afterwards, why not do the treatment beforehand to help you with your planning and treatment using SureSmile? It's going to make life so much easier. And the patients get an immediate win as well. The patients will get a win from this. They'll see an improvement. They'll see what you're doing. So everybody wins for this. Compromised treatment plans can give excellent results. Going back to that previous case, he's a compromise. He was a compromise in that he was never going to correct that class 2. He was always going to have some form of deep overbite. The adjustment to the lower incisors gave me the Dahl improvement as well. If you know what Dahl is, it's where you build up the lower incisors or the uppers, open up the back teeth, and they will close together, but it will decrease your overbite. So as well as helping move the teeth, will reduce the overbite at the same time. Non-plan compromises are excuses. So, you get to the end of the treatment, you're like, well, okay, I'll do this, do that. You're just making excuses. Plan it properly. If it's a compromised case, tell the patient, do what you need to do. If you need to do some adjustment to the teeth beforehand, don't feel afraid to do it. And essentially all that is IPR and bonding. You're just doing it beforehand, not during, but doing it to help you. This patient presented to me after approximately 2 years of aligners. This is how she came in. Now, she had an upper left C extracted and a lower left 1 extracted. This girl is in her early 30s from memory, and that's how she was left. This was on her, this is basically from her Instagram feed. And you can see, and she's given me permission to post all this. So look how much she was in aligners for God knows how long, okay? And she had a lower tooth extracted, and whatever was done or planned, that's how she came to me, totally distraught. And what's not been done there has been no IPR. There's been no plan as to how she then moves forward. I mean, bone loss was around 80% on that central that you can see. I mean, long term, and she knows this, that those teeth are going to be lost at some point. I don't know when and how. But this is exactly why you should be using IPR. Now, whether or not that tooth should have been extracted or not, I have no idea. I wasn't there. I don't have all the data. But what I can see is she's left in a really poorly aesthetic, compromised position, and health as well. So I mean, it was devastating to see this. Now, in the same visit, I bonded her up. So we did some composite bonding. We made it look great. She's happy. But essentially, how those teeth are going to stay there, I have no idea. We put a fixed retainer on the back, held them in place. Well, splintered is probably the best description rather than a fixed retainer. But that's why you do IPR as well, to avoid the bone loss, of extraction like that, to avoid the black triangles. That's the most extreme case of non-IPR that I've ever seen. And I said compromised treatments give excellent results. This patient came to see me. I finished it recently. It's a class 2 div 1, deep overbite, the tooth width discrepancy, and a severely proclined labial segment. So look at the upper right one. You'll see how it's much wider. She's had a median diastema, and someone just banged a big composite in there and said, oh, there you go, space is closed. Well, yeah, but I mean, it didn't look great. She knew it didn't look great. You can see there she had lower crowding as well. Some severe crowding. So you've got a bit of an issue there. You've got spacing on the upper and you've got crowding on the lower. Well, something's got to give. And with all the will in the world, IPR wasn't going to correct that lower area. So I did take a tooth out. So I took out the 31, the lower left one. And you always extract the tooth with the poorest outlook. And again, I took the one out which had some buccal recession, allowed the tooth that's placed lingually to come forwards, retain that tissue, and show you the plan of where we started. So again, this is slightly on a different system. This is on the ortho platform, guys, and this is using low dose CBCT as well, which is why it's meshed in there. But just to show you the case, look how wide that tooth is. I mean, I think I'm showing more here. Let me just finish the video. Here we go. There we go. Yeah, so I want to show how crowded they are. There's no way IPR was going to correct that. So, and I took out the lower left one there because if I'd have brought everything, I'd have had to expand her, but I couldn't expand her because I had spacing on the top. So an extraction had to happen, and therefore I took out the tooth with the highest risk of IPR of recession. And again, we have to accept the fact she's going to have an overjet still. She is. It's a compromised case, but compromised that's planned correctly. And also, I know at the beginning that there's going to be a big black triangle, very much like the other case, but I'm planning it beforehand. So it's not an excuse. It's a compromise and it's a plan. Okay, so she knows about this. We've discussed it. I said, look, we're going to take the tooth out, but we can have a space there, a big black triangle, and we'll correct it at the end. So she knew what, she knew when, and she knew how. That's really important. And again, it shows the IPR. Now you'll see I'm doing 1 millimeter. Oh, I've gone back. Sorry. Let me get back. Let me do that again. I'm doing 1 millimeter of IPR at the front, which sounds massive, but don't forget this here on the mesial aspect of the upper right one is a composite filling. So I know I want to make that tooth smaller, and actually it's going to be asymmetric IPR. So I'm going to do the majority on that right side. And again, this is using IPR to our advantage. We want to reduce that filling size. We want to create space. We want to tip those teeth back and reduce the overjet as well if we can. But again, I've also got 0.4 IPR in other areas as well. It's going to help me camouflage that class 2 division 1 malocclusion. Keep running through this. There are my attachments. I've got my attachments on there. You can see how the treatment progresses through, how the space closes. But again, you can see how, I mean, that papilla is never going to develop in that lower area. And we're going to have a big black triangle there. But I'm aware of that. She knows that. We've discussed it. And we're all good with that. So we'll let this keep going to fruition. And then I think, oh yeah, and we'll see where we are there. And again, I'm just showing the black triangle really. But again, she knows about it. We've discussed it. We know where we are. And here you can see the case. So you can see the before at the top on the right. You can see the post-treatment SureSmile on the top left. And again, that's me at the bottom, just finished off. I've done some tidying up of the centrals. I've done the IPR I've done the bonding on the lower. and that was planned. Okay, with a planned extraction. I used IPR on the top, but I used extraction on the bottom. So you can combine. I mean, it sounds strange. You got to take one out on one side and then IPR on another side. But so we're creating space and create space in different ways in different arches. So um, you can use IPR, you can use extractions nicely, but always plan and discuss the patient the outcome, because she was worried at one point with the black triangles. I'm like, don't worry, you'll be absolutely fine. It's all part of the plan. So as long as you're planning it, it's all good. And again, before and after the smile. So it was a really nice result, and she was really pleased with that. Also, other compromised case. I'll show you this one. This is another compromised case. It's a extensive IPR on a class 2 division 2 malocclusion and can give extra results. Now, this lady walked in. I want to have my teeth straight. I don't want fixed braces. I want aligners. I'm like, oh my God, okay. How am I going to treat this? And again, a class 2 div 2 is probably the hardest case. I'm not quite finished it yet, but you'll see where I'm up to with this. I mean, look how measly inclined those laterals are. I mean, really difficult. And the secret here is not to push that upper labial segment too far forwards. If you push those upper centrals forward, she's going to look like a horse. She's really going to look goofy and bucked. And you've got to really try and moderate that if possible. So let's look at this in a bit of detail. You'll see exactly how extreme she is. I mean, it's a pretty difficult case. This she's full class 2. Look at the canines; they're in class 2, and the 6s are class 2 as well. And the beauty of low dose CBCT is you get to take the gum away. You can see the teeth and the bone. You can see exactly what you're trying to achieve, and you can plan your tooth movements based on that. And that's the proposal. Okay, so as you'll see, what I've done with my proposal, let me go back. What I've done with my proposal is I've not actually fully corrected her. And I'll often do that. I'll often not fully correct. I don't know if you can see me, get back a bit further. I'll often not fully correct a case. You see this upper lateral on the left? I've not fully derotated it because I knew I would need to do refinement at some point. So let me keep it simple for myself. Let me not try and overcorrect it, and let me just see how it goes. So I'll often do that. If it's a case like that, I'll take it so far and I'll start the process, knowing full well and telling her that, look, it's compromised. I'll need a refinement. Let's see how we go. And look at my IPR. Okay, 0.5, 0.8, 0.8, 0.5, 0.5, 0.5. But I know that distally, I've got more room for enamel removal. Now, I've not taken all that away yet. I've probably done 0.6 where the 0.8s are. I've left some in the bag, and that's why I want to see where I go. So the top was at the beginning. The left, the upper right, sorry, is midway, and is that the same one? That's the same. Let me see where I am now. Yeah, so you'll see where I am now. So on here, you'll see how I've started derotating everything nicely. So we're doing really well with it, and she's really pleased where we're up to. The lows are straightforward, but it's the uppers that you can see where I'm slowly settling down. And it's all about talking those roots in the right way as well, in the upper centrals, bringing the roots back, not just proclining the crowns forwards. And so using IPR, there's no other way of doing it. I wouldn't want to take a tooth out. She's narrow anyway. So I've expanded her and I've used IPR, but I've taken IPR from the distal aspects of the tooth based on that research, knowing full well that it's thicker at the back, but I've not done it all. I've left some in the bag, and I know I can do more IPR if I need it. I need to see how far the expansion goes. If you look at the lower left, you'll see, look at the 5 and look at the 5 on the lower one. Look at it at the beginning and look at the bottom. And you see how we're expanding it quite well as well. And you can see there, look at the arch expansion. You can see how wider our arch is now as well. So we're getting through it. They're uprighting. And when we talk about expansion, we're talking about rolling out the teeth. So teeth lean in. Palatal teeth will lean in like this, and lower linguals will lean in. And you want to just roll them out. You don't want to do bodily movement. And I'll show you in a minute kind of what you shouldn't be doing when you're expanding arches and how IPR can help you. So again, we've expanded the lower. There was no IPR on the lower at all. That's all purely by expansion. And there you go. That's where she is currently. That's the picture I want to show you. So you can see how even though we've done IPR of probably 0.6 in some areas, you can't really see. You can't tell. The teeth look perfectly healthy. I've got a nice alignment of the teeth. Things are improved. Look at the canine, how far the canine is improved in its position. It's almost class 1 on the right. Much better position. We also do asymmetric IPR. IPR is great if you want to correct a centre line. This patient had a centre line shift to the left. Want to bring it across the right before we place the crowns. She's got crowns. In fact, I'm not doing the crowns on this patient. My business partner is. He said, "Look, what can we do here? Because I need to move that centre line across." And she's got crowns on the upper right 2 and 1, and the upper left one is heavily bonded, I think. And so basically, as you'll see, we did some IPR. We started shuffling things across. So the teeth are moving. It's a slow process, but we're slowly moving that upper right one across. It's root filled and crowned as well, and post crowned as well. So it's a bit of a tricky one. But you can see how actually on the gum margin of the one, you see how we've changed. And actually, the recession's resolved by improving the position of the root. So something to be careful with. And this is a case, I was doing a one-to-one and a colleague showed me a case and I was like, okay, let's look at this. And do you mind if I show this at the webinar? Because it's an important tale based on what we've discussed this evening. And so this case was shown to me, and it was the lower right was a tricky area, trying to get that lower right 5 in line. And essentially, it was a case of trying to expand and do some IPR at the same time. And what was planned was some IPR, as you can see on the lower, on the right side, 0.5, 0.5, 0.4, 0.4 with some attachments, and some IPR on the left as well. And those are the attachments. Now, for a start, to also discuss the attachment where the lower right 5 is, that attachment, first of all, it's very hard to place. So if you're ever going to place attachments on a lower 5 that's like that, it's tricky, okay? And it's very hard for the aligner to grab that as well. So just be aware of that. But what wasn't discussed or wasn't looked at, there was no IPR on the lower incisors. The IPR was only in the posterior, on the lower incisors on the right. It was only in the posterior areas. And you see how the IPR was staged through. Now, the plan was to move the teeth into this position at the end of treatment and for the lower incisors to be like this at the end. But what's been missing, and if that's the final result that was being planned, look at the black triangles that were still present. So there's a lot of potential to actually do IPR at the front of the mouth rather than just at the back where the crowding issue was. And so the tale from this was use IPR in areas where it will benefit you and the patient, and you'll get more than one win. So by doing IPR in these lower labial areas, it would have allowed this case to be done in a much more straightforward way and less IPR needed posteriorly. I hope that makes sense. But there are lots of black triangle in areas where more IPR could have been utilized. So that's at the end of treatment. Okay, so there's a lot of scope for more IPR to be done here. And the reason that's important is because look at the movements that were proposed. So that lower right 5 was going to be moved buccally and bodily as shown. And look at the bulge of the tissues on the visual on the right hand side. Look how it's bodily moved. Look how the root's been pushed out, and that's almost, I would hazard to say, being pushed out of the bone. Okay, so by virtue of not enough IPR in the best possible areas, and again, the lab will do this and haven't really considered it because they do as they're told. This tooth will have been corrected and moved, but corrected possibly to an expense of some recession, of bodily movement outside the bone, whereas actually it could have made it a lot easier by doing IPR at the front of the mouth and into proximally more to reduce black triangles, and therefore just allow a tipping movement of the tooth rather than a bodily movement of the tooth and the root. Yeah, so again, you can just see here how that tooth has been literally, and that's essentially the final result that's been proposed. You can see how that root area there is almost being pushed out of the bone. So this is something to be very aware of and very careful of, and therefore use IPR more in these lower labial areas to create space to help resolve these posterior areas, in a better way. biologically as well. Now, just so you're aware of this, I'm just going to pause this actually. There is a tab on Ortho Align which says, I'll go back actually, you can see it again. Request modifications. I don't know if you've seen this, but rather than just write comments, you can actually request modifications, and actually it will show you the movements that are being proposed. Oh, I'll go back, sorry. Okay, gives you a little comment, but then it asks you, you can actually see here each movement in 3 dimensions that each tooth's being asked to do. And you can see the lower right 5, buccally was moving 4.2 millimeters buccally. That's a long way for a tooth to move buccally. Okay, and being taught 19 degrees as well. So that's a 4.2 millimeter movement, a 19-degree buccal, and a derotation of 26 degrees. So we're doing massive movement on this tooth. And actually, it would be a lot nicer for the tooth and a lot healthier if we had more space back there and we just tip the tooth rather than try and push it through the bone and kind of push it into the abyss, essentially. It may not have moved anyway, but that was the intention. So it's important when you look at your plans, you look at what actual movements are being proposed and seeing actually if you think they're feasible. As we go through, you can change the parameters as well. So you can actually modify this and change the parameters yourself to see what it would look like, if in fact you made the changes to either the amount of torque or the root rotation. And like I said, I'll often do less initially and then review it and then refine later on. I think it's safer and it's more controlled that way as well. Okay, so essentially IPR, it's amazing and an invaluable tool and it assists in your treatment. So don't be afraid to use it, whether it's just some minimal IPR or whether you're doing some more extensive treatment and IPR is needed before or during the treatment. I do a lot of my IPR at the beginning. Majority I do at the beginning because I want to visualize where I'm going. I know what I need. I want to be in control of that. And the patient doesn't want treatment every time they see me as well. They don't want me to be a drill up every time I see them. So in fact, there's actually benefit that way. I know what I'm doing in a way, and it's controlled, and I know that I might need to refine, but I don't mind that because that gives me more control. Going back to what Christian said about the one-to-ones, I think he mentioned, just so you know that anybody that wants a one-to-one, we can arrange those for you myself. Speak to your CIS and they will get in touch with Natasha, who will message me, and my PA or myself will be in touch directly, give you some dates. We do it through on a portal that I have. We started using this portal during COVID, but it works really nice. I can share my screen, share your screen, we'll look at the case together and give advice on how you move forwards. You'll get an email or a message stating the time and date and a login and a link to link on. Make sure you can share your microphone and you've got video access so I can see you and we can chat. You log on, you go in the waiting room, and then I let you in and we chat through it. If you want to contact me directly, by all means, on WhatsApp as well. And I hope that was helpful. And I think that is it.
Brilliant, that's great, James. Thanks ever so much. And now I can only suggest, guys on the call, if obviously there's any questions now, please do feel free to come off mute or drop a quick note in the chat, and we can have a discussion now. Appreciate when there's 25 people of you, which is brilliant. You might not want to discuss this in front of everyone, but please do reach out to either myself or Natasha, or as James has shown, to arrange a follow-up one-to-one call. Be delighted to hear from you. And the sessions James has done with other clinicians in the past have worked really, really well. The feedback we've had from the clinicians has been fantastic. So to be able to do this as part of the SureSmile support is a really, really useful tool. I've got a massive long list of questions, but I'm not clinically trained. So James, I'll go through these with you when I see you in your surgery next week, actually, funnily enough. Yeah, I did recognise one of those photos as well, actually, James.
Yeah, I got permission there from the patient.
You did. But other than that, I'm not seeing any questions in the chat. Does anybody have anything they'd like to ask while you've got yourself? Right, there's one there coming through from James Clark. Can you advise how do you measure or gauge your IPR accurately if you're doing it on teeth without good contacts or if using a burr at stage 1?
Yeah, okay, so the answer is you've got to just go for it, and essentially it's a judgment call. I'm not, I can't accurately determine whether it's 0.5, 0.15, 1.5, 2. There's always going to be some area of discrepancy there. You, you should know what 0.5 millimeters looks like, and and if you get the gauge, you'll see. But it's a bit of just, it's trial and error as well, I guess, and a bit of finger in the air. Is the wind blowing east or west? But most of the time, again, you're shaving very fine amounts off, and so you can gauge pretty easily. And if you get one of the gauges that tells you the 0.1, 0.2, 0.3, you can absolutely work out where you should be and where you should be stopping. So yeah, I mean, it's not an exact science, isn't that, the pre-treatment? But the beauty is you may then need a little bit more, a little bit less expansion. Because if I'm doing it pre-treatment, then I can build that in. If I'm doing it after I've planned it, but before and while the teeth aren't in contact, then again, yes. I mean, it's not going to be 100% accurate. But then what really is? You could do the IPR to 0.2 millimeters. I can hold that tooth and just move it with my fingers, and I bet I can close it by 0.1 millimeters. So dentistry is an exact science until it isn't, and we all know that very well. Why do some things work amazingly and some things don't? But I tell you, but because you're dealing with and the aligners and the tolerances, the majority of times you're going to get it bang on, and I won't be too worried about that, because you 0.1 millimeters between friends is not really a lot, to be honest.
Excellent. Thanks, James. A couple more coming through now. So, one from Nahida. I've just registered, so I'm new to the world of SureSmile. Are you wary of carrying out IPR with bonded crowns?
Say again, sorry. Can you
Are
do?
you, are you wary of carrying out IPR with bonded crowns?
No, not at all. I'll do. No. Again, when you talk about bonded, I presume you mean you talking about dentine bonded crowns, or you talking about porcelain bonded to metal? I don't think it makes any difference. If a porcelain bonded to metal, or a PFM crown, or whatever you want to call it, then no. I mean, I just treat it like tooth tissue. I'll bond that and I'll modify that. So I'm not concerned about that at all. I'll absolutely adjust the porcelain. Make sure you use water though. If you use a burr without water on porcelain, it will chip and fracture. So always use water. Keep it cool on porcelain. Really, really important. So now I'll adjust that. If it's a dentin bonded crown, that's perfect, because it's taking integral strength from the bonding to the tooth. And again, I'll adjust both in the same way I'd adjust a normal tooth. Same, I'd use it the same. No issue.
Okay.
Use water.
That's great. He's already responded. That's great. She was worrying about fractures, so that's great. Nice comment from Agnieszka. Apologies if I pronounced that incorrectly, but hi James, your composite bonding and closing black triangles look great. Are those freehand? Could you do a webinar on your technique?
Sure. That's all freehand. I've done one case of pre-designed with a well-known brand of pre-designed, digitally designed, and I hated it. So I'll do bonding. When I composite bond, what you've seen there is all freehand. So I'll do it all freehand myself. And again, it's just about visualizing and bonding. And with pleasure, I can, if Christian wants to arrange it, I'm more happy to do some video and show how I do it. But what I will also do though is I'll also do a lot of mocking up, which I think is really important. So, and again, I guess I could share that as well. A lot of my, whether it's SureSmile or whether it's pre-treatment, I'll always mock up. So I've always got a whole batch of composite. A patient will come in and we'll talk, say, do you know what, let me show you. And very easily I'll freehand the bonding, and I'll demonstrate to the patient what I can achieve. And I'd say that's a skill you should really work on, because you guys are, you're dentists, you're artists, you mold, that's what you do. You don't need a technician to give you a standard spec tooth on every patient. The beauty of dentistry and of what you do is you're going to take the patient's DNA and you're going to just enhance it. So I like enhancement. I don't like transformation unless the patient requests it. So I'll always enhance. And that's why I like edge bonding rather than full veneer bonding as well. But I'm more than happy to show you how I do that. But all my bonding that you see, everything's freehand.
Excellent, that's brilliant. Good question from Lynn. Teenage patients, are you more cautious with your IPR on teenagers?
I don't know good reason why I would be. No, if I need to IPR, I'll do IPR. So the question is with a teenager, why are you doing IPR? So are you doing it? Well, I'll start again. Any orthodontics on a teenager should be ideal. It should be compromised orthodontics. That's the first thing. You're always going to try and achieve a class one occlusion. Now, if you're trying to achieve a class one occlusion, all the teeth are there. The Bolton analysis, which talks about the percentage and the proportion of upper to lower teeth, should kind of work if the teeth are the right proportion or the right width to height, and therefore it should come together. Nature dictates that teeth should meet like this, and so I'm only doing IPR if it's going to need if it's of benefit to the patient. So if there's tooth width disproportion, then IPR is definitely going to help. So there's no caution with that because I'm doing it to benefit the patient to get the best outcome. If I'm doing it instead of an extraction, why am I doing that? I'll do some big IPR if they've got a lower E retained because it's wider than the 5, and then I've got loads of enamel measly on that. So I can do some heavy IPR on an E. But other than that, IPR on a kid is only really when if it's non-extraction and there is some disproportionate tooth widths. That's probably the only reason you use IPR, unless you've tried to expand and you can't expand as much as you want to, and you want to decrease an open bite. The very limited reasons why I do IPR, but if I need to do it, I wouldn't be cautious. It's enamel. I mean, it's glass. So just, this is what you guys do. You train to use a handpiece, but only use it. But again, plan it all, and then it's not a compromise then.
Okay, excellent. Another one. With the case you built up the lower 2-2 before starting treatment, are you worried about fractures, or would you do 3-3 to give more of a Dahl effect? Sorry, I'm obsessed with fractures.
Well, Dahl works on. I'll do Dahl on. Well, okay. So I'll do Dahl with 2-2 or 3-3. It doesn't make any difference. I'll also use turbos now. I don't know if you might not know what turbos are. So 3 or 4 years ago, I started doing Damon orthodontics, and Damon works on expansion. They're the self-ligating brackets. There's no elastics around, and that's blew my mind because it involved discluding the bite with what's called turbos. And turbos are literally 2 pieces of composite, either on the centrals, on the palatal aspect, and literally the mouth is propped open like this, or on the 6s. And I couldn't get my head around it for some time until I started doing it. And so, and what it will do is it will decrease the overbite, and it will allow expansion. So no, I'm not worried about it. In my hand, I've never had any fractures on the back of that. I've even had composites don't fracture either on the back. No, nothing's really fractured. The body has got an amazing way of accommodating and making things work. If you prop it open at the front, the back will come together. It just happens. Okay. So Dahl works. It's really effective. And with a case like the one I showed, it's never going to be perfect because it's still going to have a deep overbite. I tried to make it less traumatic, and I managed to do that, but he's still going to have a deep overbite. But I managed to level the curve of SPI a bit. And he's fine. So he benefited. And the same with that patient whose photograph we saw, who I'll be treating next week. Same problem. We'll be bonding the lower 2-2, maybe one of the 3s I think on the left, and we'll be reducing the curve of SPI by nature of the ortho, and we'll decrease the overbite. And but I doubt anything will break. Be fine. So Dahl works. It really does. It's really powerful.
Brilliant. That's excellent. I think that's everything now. Unless if anybody's got anything else, please do feel free to come off mute and join in the conversation. But you've seen both James's, Natasha's, and my contact details. You've seen the opportunity there to book a one-to-one with James, and I would certainly urge you to do that. Certainly, if there's anything more detail or any cases you want to share with James, particularly with IPR, please do book on some of those one-to-ones. As I mentioned right at the start, that we've got the next session next month with James, which is all about best practice communication with the lab, and this is something that I know James is very, very, very hot on, and it is about minimizing the risk of complications arising further. You communicate effectively with the lab, you are going to make for a smoother process.
Yeah, if I can add, it's really interesting because we actually had a call with the lab in the States or in Mexico last week, and I'm actually going to interview her. I've got a set of questions that I want to ask because I have issues too. I still have lab issues, and so it should be quite interesting because I'm going to press her on exactly what they do there and how they do it. and actually also find out what issues they have with us, what we can do to help. So I'm looking forward to it for my own benefit, really, not just for you guys.
Yeah, it's going to be a really, really useful
It'll help
session.
me too.
Definitely. But if that's everything, unless anybody's got any further questions, I'll bring the call to a close. Just want to say thanks very much again for all of your time joining us this evening. It's been another fabulous session again, James. That's been brilliant. Natasha, anything from yourself before we close?
Just to say a huge thank you to James for this evening and for all the one-to-ones over the past 8 weeks. We've had some incredible feedback, so yeah, thank you, and thank you for being so accommodating and flexible.
Brilliant. That's great, guys. Thanks very much.
Thanks, everybody. Have a good evening.
Well, and hopefully we'll see you again next month. Take care, all. Bye bye.
Thank you. Bye bye.